It's time for bold moves. I also am excited about the fact that they are focused on the root causes of chronic disease. The healthcare system tends to bear the brunt of all the complaints, but in fact, the food we're eating and lack of walkable communities and those kinds of policies are contributing to chronic disease. We need to talk about the upstream reasons that we're sick and not necessarily only about, how long does it take you to get an appointment with your primary care provider or how much prior authorization do you have to go through? Let's talk about food additives and agricultural subsidies that make corn syrup cheap. I'm looking forward to talking about other things besides hospital lengths of stay.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
When Krista Drobac arrived in Washington, D.C., fresh out of college, she had no car, no connection, and no clear path. Just a determination to make a difference in politics. What began as a leap of faith quickly turned into a lifelong mission to transform healthcare policy. Today, as a founding partner of Serona Strategies, Krista is a driving force behind some of the most innovative approaches to care delivery, from telehealth to home-based models. Her career took root in the late 1990s when she led a groundbreaking campaign for stem cell research, uniting patients groups to advocate for life-changing treatments. Since then, Krista has become a trusted voice in healthcare policy. She's a true leader focused on spotting growth opportunities and mitigating risks stemming from policy changes at both federal and state levels. By merging market dynamics with regulatory shift in Medicare, Medicaid, and commercial care, she guides companies from startups to Fortune 10 giants in building models of care that capture new opportunities. With deep relationships across both industry and government, and a rich history in United States Senates, the Obama administration, the National Governors Association, and state government, she's uniquely qualified to spot trends that drive change. In addition, she founded 3 coalitions dedicated to ensuring patients have access to telehealth, more home-based care, and integrated social services. In our conversation, Krista takes us behind the scenes of her journey, from her early days advocating for stem cell research to her current efforts to revolutionize care delivery. She opens up about the challenges of balancing innovation with affordability, the importance of addressing the root causes of chronic diseases, and why now is the time for bold, transformative ideas in healthcare. Listening to her, I could not help but feel inspired, and I hope you will too. Here's our conversation. Welcome, Krista. Thanks for joining today.
Thank you for having me.
It's so nice to have you. I'm looking forward to our conversation. We have so much to cover, and I always like to ask a little bit about your personal story, your journey, and what got you excited to be in healthcare and be in a policy.
Well, I showed up in Washington, D.C. after graduating from college. I did not know anyone. I didn't have a car or a place to live. I just knew I wanted to get involved in politics. So I lived with my ex-boyfriend's second cousin, found myself a job, and I didn't necessarily know I was going to get into healthcare, but some of my early career experiences were with patient groups, and it became a real interest of mine. So after I went to graduate school, I got my first policy job in the Senate, and I was able to take over the entire health portfolio because I was working for a freshman senator, and freshman senators don't have a lot of budget, so they don't have a lot of staff. So I had a huge opportunity there and just fell in love with healthcare policy, and it just sort of all flowed from there.
Yeah, well, you mentioned that being in the patient group. What are the things that got you interested in healthcare? I mean, is there a moment that make you feel like, wow, this is something that I want to be doing?
Yeah, well, it was in 1994. 2007 when stem cells were first discovered, and there was an effort to use embryonic stem cells for research on disease. And there was a movement on the Hill to ban federal funding for stem cell research. And the patient groups that we brought together, Parkinson's, spinal cord injury, juvenile diabetes, all of these patients were really passionate about finding cures. And so we created a group called Patient Cure. It stood for something, I forget. Patient Coalition for Urgent Research, I think what it was. And we just implemented an entire campaign. We were doing media, we were on the Hill, we had patients groups meeting with members of Congress, and we're so passionate. And it was just a really interesting overall experience. I have recently, been mostly involved in digital health and new models of care, like care in the home, or basically just new ways of thinking about how to deliver healthcare. And I suppose it could stem back to there because stem cell research really was a new way of thinking about cures for disease.
Mm-hmm. Well, the nice thing about innovation, they're constantly looking for a way to solve problem that has not been solved. And sometimes being in healthcare, it can make you feel inspired, excited, but it also can be dejected that things seems to move.
Things go a little slowly.
Slower.
That's right.
And I think sometimes being in policy is such an important piece when it comes to healthcare. And tell us a little bit more as a regular people, like how policy shape what we experience healthcare, the impact of policy.
So the murder of the United Healthcare CEO a couple weeks ago really rocked our world in Washington because we generally debate these issues passionately. But the idea that there's enough rage out there that it would result in murder is just beyond our comprehension. But I guess it relates straight back to your question, which is how is public policy impacting real people? And the Medicare Advantage program has tremendous advantages. So much flexibility, and they're offering patients, vision and dental and all kinds of benefits that they can't get in fee-for-service. But there is a prior authorization process. And that prior authorization process, is debated on Capitol Hill. There's a prior authorization bill that was going to be included in this end of year package that's going to be voted on Friday. And so it is a legitimate policy debate. What do we do about prior authorization? Because we have to balance it with healthcare costs. But that trickles down. And just like many other decisions in healthcare policy, impacts real people.
Yeah. And I think it's easy to blame one, but then it seems like everybody has a role.
Yeah. I go back to the system and the way we set it up. It's the incentives. How do you incentivize behavior? You're going to get the behavior that you've incentivized. And if we've said to managed care plans, here's the benchmark at which we would offer a fee-for-service plan, come in below the benchmark, and you can use the delta to plow back into new benefits for beneficiaries. And the system is set up that you're going to compete against other health plans for beneficiaries. That sets up a system that you want to save as much money as possible so you can plow them into excellent supplemental benefits that will then attract more people to your health plan. Mm-hmm. That's the structure. So what do we expect? And everybody wants vision and dental. It's got to come from somewhere. Mm-hmm. So I go back to just the system setup, which is why my partner, Krista McGovern, and we have set up some coalitions, and we also have clients that we're trying to help change the rules on some of these things. We want more value-based care, more bundled payments, more at-risk arrangements, because it takes away the incentive for overtreatment or the treatment of the wrong things or more procedures. So you got to just change the system incentives if you want things to change.
Right. And it's easier said than done. Obviously, the system involves so many people, so many different stakeholders, different group, and they all have accustomed to what they have, and nobody like to change unless they want to change themselves. And most people don't like to change themselves either. And how do you, as a policymaker, how do you balance that? 'Cause nobody's going to be happy when something, there's something to give, something to get. How do you balance that?
I mean, so much of our debate since I've been here in 28 years is focused on coverage. What kind of coverage do you have? Do you have a private plan, a Medicaid plan, a Medicare plan? And that, when you talk about coverage, somebody wins or loses. And either the taxpayer is paying more and more people get coverage, or we're paying less and less people get coverage. I mean, there's not it's a sort of a zero-sum game where when you're talking about changes in care models, that is not a zero-sum game. If you think about it, if we incentivize the right things by going at risk, we'll have increases in primary care, which I don't think anyone would be opposed to. It's not necessarily a change. It's more of a good thing to have somebody who is at risk for your care. One of the things I'm really passionate about working on right now is creating more home-based models. Lots and lots of people want to stay home. They want the option to stay home. If you think about it, all markets, commercial market. I mean, I had a hard time whenever my kids got pink eye or strep throat. I would have loved for someone to come to my house because I wouldn't have had to necessarily take off work. Older people, seniors want to get care in the home. So there are things that people want that they're not getting. And there's also ways to change healthcare in a way that doesn't make people feel like they're giving something up.
Mm. And it almost seems like all the conversation, I feel like I've been in healthcare forever, and the conversation is roughly stay the same. Like, it's expensive, you don't get what you want. And actually, it's interestingly, after this the shooting, there's an article, I believe in The Economist, talking about majority of Americans, when they are asked about what they think about their healthcare, majority of them thinks they have a good one. But then if they were asked, like, do you think the healthcare in America is really bad? Majority of them think American healthcare is bad. So it's kind of disconnect there. It's almost like the narrative out there make them feel that healthcare is bad, when actually what they experience is pretty good.
That's right. I really do think it depends on how sick you are. I mean, if you have cancer, it's a journey. It's a long journey through a lot of different parts of the healthcare system. And I would be very interested in seeing surveys that are bifurcated by like healthcare acuity. Have you had a chronic disease or not? And then, have you felt like your life has been significantly disrupted by a chronic disease? Now, ask those people how they feel about the system versus people who are relatively healthy and feel like they're insured against catastrophic incident. I don't know, really. I don't know what the difference might be, but I guess I would say on Capitol Hill, there's a lot of discussion about affordability. There's a lot of discussion about rural healthcare and lack of access to rural healthcare. So maybe if you bifurcated those surveys and asked rural versus urban, there's just people are living in different aspects of healthcare all the time. So it's really hard to generalize. But you can make the generalization that we are more expensive than other countries and we do have worse outcomes.
Yeah. It's probably a good time to talk about, we have a new administration coming in 2025. And I felt at the same time during the campaign, nobody really talked about healthcare in the campaign. At least I didn't hear it as much. But after the shooting, you see the anger about healthcare is pretty strong out there. What do you think that might change. We talk, I think when Donald Trump was the president, they were talking a lot about repealing the Affordable Care Act. I feel like it might not happen, or it might happen. If it happened, how is that going to happen? Tell us a little bit what you think that could happen. What could change?
Well, a lot of the debate is going to be driven by other priorities and a philosophical difference between the Biden administration and Trump administration on healthcare. I would say probably very top 3 priority for Congress next year is extending the Trump tax cuts. That is going to be very expensive, and there will be offsets that will be required. The big dollar offsets are in healthcare, and the president has said that he will not touch Medicare or Social Security. So that leaves Medicaid and the ACA marketplaces. The marketplaces are subsidized until the end of next year. And so if you didn't subsidize ACA beyond 2025, you wouldn't see savings because it wouldn't be in the baseline. There's going to be no spending. If you want to continue the subsidies even at a lower rate, it would still cost you money. So they would still then have to find offsets for those subsidies, which on top of all the other offsets they need is pretty difficult to do. So I would say then the philosophical differences on Medicaid are a couple of things. One is work requirements. There is an interest in having able-bodied Medicaid adults work. The challenge is most Medicaid beneficiaries are already working. So it remains to be seen how that would be implemented. And then there are some pretty complex funding schemes for how Medicaid is funded. And I say scheme because it's a convoluted way to fund the programs, but it is still funding the programs. So if we reduced some of the quote unquote schemes, we would still be cutting tens of billions of dollars out of the Medicaid program. And so that means a loss of coverage. At the same time, they want to give flexibility to more flexibility to state Medicaid programs and be less prescriptive at the federal level, which is a good thing. So maybe we can find innovative models at the state level that are a result of this kind of major change that would be a good thing. It's hard to conceive of the new innovation that we can have in the face of cuts, but the cuts are coming. So we should think innovatively about what we can do to restructure some of these care models in order to absorb the funding cuts.
You mentioned that maybe the new administration, maybe this isn't a good opportunity to bring it back to state, for the state to be innovative with their model. Is there any state right now that you think is a good model that other states can learn from, and why is it good?
Oh, there's so many states that are doing so many good things, but it generally, requires money. I think there has been this really interesting approach of earlier intervention with people who are leaving prison. We tend to release people from prison and then you can't find them. And, those first 30 days are absolutely essential for people who have substance abuse disorder or, chronic disease. And so, so a lot of states have started these Medicaid programs where they are doing case management before the person leaves so that there's almost like a warm handoff between the inside and outside worlds so that you can reduce relapse and reduce, help someone maintain a regimen of chronic disease management. So that's just an example of a really interesting intervention that Medicaid directors looked at their data and their budgets and said, we're spending a lot of money on this population because we're losing them in a critical time period. So let's design some programs to catch them before they leave and help them integrate, in terms of healthcare into the external world. And they were able to get 1115 waivers to do that. So that's a good example of reducing your funding, reducing your expenditures by intercepting sort of root causes of some of these expenditures, and in the process helping people get better care. I don't know how we do that without funding. So that's the critical piece of this is can we plow savings that we would have gotten back into these programs somehow instead of getting upfront money, for example. It might be a way to do it, but there's lots of innovation happening. And sometimes the mother, changes the mother of innovation. So who knows? We might be forced to innovate.
Scarcity is the mother of innovation, maybe.
Scarcity, yes.
I think one of the things that people, when Affordable Care Act was passed, there's a lot of people who like it. And there's a lot of people who say that was make my healthcare more expensive. And how is that going to change for people who think that their healthcare now is so expensive? Because they have to, in California, they have to have a healthcare sort of mandate. Otherwise, they get fined.
I think the context in which this is coming up a lot lately is GLP-1s. Do we pay for GLP-1s, which are really expensive, but can save us money in the long run? So I think we're having a debate in Washington right now about how the Congressional Budget Office scores pieces of legislation, because they only look at the cost increase to the baseline. So they would look at how much does it cost for you to buy GLP-1s for a month. They're not going to look 6 months, 8 months down the line and see a reduction in your A1C and therefore a reduction in your potential, costly side effects of diabetes. Like they're just looking at that one initial cost. And so we're talking in DC, well, should we do dynamic scoring? So the CBO can look down the line and see things that might reduce costs. And there is a bill that did pass the House this year that would have given CBO the ability to look down the line. But it hasn't passed the House and the Senate yet. So we are going to continue to just score things as how much extra money they're going to cost taxpayers to put into a healthcare package. But someday we could look at it more holistically and say medication management or, more primary care or greater intervention for people with chronic disease. And those things could end up saving money in the future. And that will make it easier to pass legislation that could appear that it costs money, but in fact will save us money down the road.
Isn't it sometimes hard for the politician to convince the voter or, somehow their opponent would say, like, look at that, they spent more money because the saving down the road is down the road. And how do you balance that?
Generally, voters like upfront expenditures. I mean, if you think about adding Part D to Medicare, that was a big expenditure. But voters wanted a Part D plan. So, I mean, that cost us money on the upfront. And now seniors have access to medication. I mean, most of the things that are in Congress right now that cost money are things that are favored by seniors. I work a lot on telehealth, and people want to be able to visit with their providers virtually. But it costs money.
Right. It costs money because they get the benefit. It's just like if you cover the drugs, me as a citizen don't have to pay for that drug. That's why the citizen like it, because it doesn't come out from my pocket, but it comes from the country pocket. And then the other people who did not get that benefit get really upset.
Yeah, well, I think that this comes about a lot in Medicaid because you could have someone who has a low income job that's paying for care on the marketplace, and they're paying high premiums, and then they have a high deductible, and their neighbors 2 doors down might not be working. They might have a disability and they're getting Medicaid and they don't have any copays. And so I think the disparity between Medicaid and the sort of the first step in insurance, which is generally the marketplace, or an employer package that's low premium, which might have a high deductible plan associated with it, that probably is where you see this most. That, why do I have a $3,000 deductible and you don't have any copays? I think that's probably where you would see that happen.
It's almost that's the beauty of this country. Everything is customized. Everything is different.
Yeah.
But the devil's always in the details.
Exactly.
But nobody have the time to look at the details.
Yeah, well, I mean, this is the philosophical, like, if Americans really read the details, they probably would have understood some of the philosophical differences between the left and the right. I mean, the left believes that we should all collectively care for each other because you don't know who's going to get sick at what period of time. So therefore, we all pay a lot to make sure that if we end up being that person who's sick, that we're going to have coverage. The Republicans think that we're individuals, and if we had control of our own healthcare dollars, we could spend them as we saw fit. And if everybody spent their dollars rationally, we would be spending money on things that make sense. And so we need to unleash people and individuals, and then we would have better healthcare. So it's like you probably couldn't get more different in worldviews on the two sides. And so every time we have a change in administration that changes parties, it's just this push and pull between individual and collective action.
Mm-hmm. Do you think, it feels like the healthcare has been like all about insurance. The employers cover the insurance. There's a Medicaid, there's a Medicare. It feels like the Democrats' way of covering healthcare seems to be kind of more happening. The Republican is trying to, strip that away so that more and more people just like, maybe I'm just totally guesstimating. It's like maybe their idea is like, hey, we'll give you money, $100 per month. You decide what you want to do with it. Is that the direction they want to, the Republicans think?
So there was a illustration, a metaphor, when the Republicans first took control in 2017, and it was a healthcare backpack. And you are born with a healthcare backpack. And in that backpack is an HSA. So you'd be born with a health savings account. The idea being that the government seeds the health savings account and that money grows over your lifetime so that when you need it the most, when you're a senior, you have the biggest amount of money because it's been growing over your lifetime. So you will have money then when you're older to spend as you see fit. And again, if everybody spent it the way that, is rational, we would have a more rational system. Also, you have your health records. They really want interoperability and ownership by the patient of their own records. And it goes along with the idea that you control your healthcare. So you can't go to a provider when you have to harangue your old provider for your records. So they really want people to keep their own records. They also want price transparency because you can't shop well with the money that you have unless you can tell how much things cost. And then they want you to be able to see whatever doctor you want. So they're not big on provider networks because, again, it blocks you from acting rationally. So if you had your own money, your own records, you didn't have to stay within a provider network, and you knew how much things cost, you could be a rational actor in the healthcare system, and we would all be better off because everyone in economic theory would act rationally.
Mm-hmm. Well, the way you said it, it sounds pretty good, actually.
Yeah, there's some challenges. I mean, one of the things, if you want to speak in economic terms, there is asymmetry of information in healthcare. If my doctor tells me I need an MRI, I'm not going to say, can I get an x-ray because it's cheaper? Because I don't know. I mean, if my doctor tells me I need an MRI, then I need an MRI. And it's harder to shop when you don't have the information that you need to make the decisions about what the treatment is that you need. So if somebody recommends an expensive treatment, you're probably going to do it because you have inelasticity of demand too. You only have one body and, and one health. And so if somebody tells you need an expensive treatment, you're probably going to do it, because if you don't, you're going to be worse off. And it's not like you could live without, the new treadmill that you wanted to buy if you found out that it was too expensive. So I would say asymmetry of information and inelasticity of demand make that theory pretty difficult. But they have governed very much that way. In the last Trump administration, we had like leaps forward on interoperability and allowing people to keep their own records. We had leaps forward on price transparency. There's a lot of really good things that can come out of it, and they have been adhering to that sort of theory.
Mm-hmm. I want to ask you this question because I feel like, well, depending who said it, there seems like a lot of polarization between the Democrats and the Republican, and the people who vote for Trump thinks the Biden do everything that he does is bad, and the Biden voters thinks everything that Trump does is all bad. Is there anything good that what are the good things that came out from the Biden administration, and what were the good things that came out from the Trump administration for the healthcare?
So I would say there's definitely areas of bipartisanship. One of the things that the first Trump administration placed a lot of emphasis on is burden reduction. We have a lot of burden on all parties in our system. Providers are spending way too much time on their electronic medical records. They have what's called pajama time. They're going home at night and dictating their notes or filling in their records. I mean, that is just way too burdensome. The billing for healthcare is way too burdensome. For patients, getting things prior authorized is burdensome. Getting reimbursed appropriately. I mean, there is burden everywhere across our system. And so there was a burden reduction caucus. They started a burden reduction office. I think that is a bipartisan issue that Trump started. That is great. There's also big emphasis on telehealth, digital health generally. I think that is something that the Republicans have leaned heavily into, is also bipartisan. But, Seema Verma came into office when she was the CMS administrator and said, I really want to impact telehealth. I want people to be able to see their physicians virtually. And they did it. So I think those are a couple things that came out of the Trump administration. The Biden administration's been working really hard on value-based models. How do we incentivize the right things to save money? And so the models that they put out in CMMI, the REACH model, they've been trying to essentially give healthcare players the opportunity to take risk. And that, again, is also a bipartisan effort. But we can't fix what's wrong in healthcare without changing the incentives and changing risk.
And how do we do that? It feels like everybody knows changing the incentive. And how do you, and almost sometimes it's easier just uproot everything, but that's not realistic either.
Yeah. Well, I've been working on a couple things that I think are good illustrations of how we change risk. The first is, they're both moving care into the home. The first is a primary care bundle for people with chronic disease in their home. So a senior could decide, most seniors have multiple chronic disease, but you could choose a primary care office, quote unquote office, that's in your home. So it's like a mobile unit, and you have access to the primary care provider, a nurse, a community health worker, like a whole team of primary care professionals. Depending on what your needs are, you would have access to those people, either virtually or in person in your home. It is absolutely essential that primary care providers see the whole you, and going to your home, looking in your fridge, looking at fall risks, looking at your social situations, even how you sleep. I mean, that can contribute enormously to primary care. So if we said to a primary care provider, hey, you want to, get out of do you want to sort of get out of your office sometimes or all the time? Here's an opportunity to treat patients in their home, see their living conditions, see them, all their medications and how they're taking their medications, see how they go up and down their stairs, and then create a care plan that can be implemented always while the patient is staying home. But we're going to give you a bundled payment. So we're not going to pay you in a fee-for-service basis. Then all of a sudden, their provider has the incentive to keep that patient healthy so they're not overusing healthcare services and being responsive. So this is what a lot of concierge care providers do right now. If you just pay a bundled payment to the concierge care provider, they'll do whatever you need. They'll be there for all your primary care needs. It would be great to be able to do that in Medicare. And I do believe that it would realign the incentives against overutilization of services and also increase the communication between primary care providers and specialists. Because again, you wouldn't want to overuse healthcare services because you're in a capitated or bundled model. Similarly with SNF at home, we're working, we've got a hospital discharge crisis right now. People are sitting in beds that they don't need to be in. It's shocking. Tens of thousands of people are sitting in hospital beds every day that they don't need to be there because they can't find a skilled nursing facility. So we want to create a bundled service that would be care in the home for post-acute. And so it would be, PT, OT, speech, physician services, personal care services, all bundled together in a 15 to 20 day post-acute bundle. And so, we really believe that we could reduce readmissions, shorten length of stay, reduce hospital infections, and improve people's mental health, improve caregiver experience, because you're bringing a team into the home and you're helping people recover in the home. So those are two examples of risk-based arrangements that would change the incentives and dynamic of healthcare while improving the caregiver, the patient experience, the provider experience, and, hopefully reduce taxpayer expenditures.
Mm-hmm. And how do you make that happen? Does it have to pass a certain bill? And what is in the docket for that?
Yes. So we have two bills. We were just on Capitol Hill last Thursday meeting with committee staff, committee members, Senate leadership. We are socializing the idea. We are very lucky in that SNF at home is following on the heels of hospital at home, which is a new innovative waiver. And so we're trying to emulate what they've already done so that doesn't seem like as big a leap, because hospital at home has already sort of paved the way. And then we have a primary care at home bill for patients with chronic disease. So we have legislation written. We're now narrowing in on the people who are going to introduce it. And then, we have to go through the regular process of getting it through committees. But we have to start a movement. I mean, people don't even think of care in the home. When they think of care in the home, they think of home health or hospice, things that are happening in the home already. We need to create new boxes, for care in the home so that people can just choose it. And they don't have to string a bunch of services together. It's already bundled together.
When I think about care at home, sometimes I feel that all of a sudden your family member, your caregiver has to take on a lot of the job that maybe the nurses in the hospital were doing. Or
Yes.
There's a lot more work on the caregiver. How do you?
Yes. And in fact, we are commissioning a survey of caregivers because anecdotally, they all like it better. They like having access to a care team because when they're in those situations where they don't know what to do, they have somebody to call. Oftentimes, caregiver burden, you would think of as, carrying somebody to the bathroom, for example. But the biggest burden on the caregivers is the burden of not knowing what to do at what times. And having a team in the house or accessible virtually or in person does relieve the caregiver of the obligation to make clinical decisions. What do I do right now? Do I give her more medication, or do I take her to the hospital? Or those are inherently clinical decisions. We want caregivers to do caregiver things. And by having a team in the home of clinicians, you're leaving the caregiver to do the things that they would do normally. And for those patients who don't have access to a family caregiver, our bundle of services includes personal care services, which are activities of daily living. So helping someone shower or cook or do the things that a caregiver would normally do. But again, we want to be very careful in these models that caregivers are not doing clinical things.
Mm-hmm. Last question before we have to conclude, as we run out of time. Being a general public, oftentimes we hear the narrative is like, it's the lobbyists who dictate where the bill is going. And you're in the midst of this bill. Tell us, what is the process so that the public, we know that, the bill is made really to benefit the citizen.
Right.
Or is it not?
Yeah, we don't, we're not going to fundraisers. We're bringing ideas to members of Congress that match up with their existing way of thinking and policy priorities. So, rural healthcare, for example, is a really big priority for quite a few people on the members on the Ways and Means Committee. And so we bring telehealth to them and say, this is a way for your constituents to access healthcare in a new way. And that is really appealing to them. So I'm not, as a telehealth lobbyist, going to big fundraisers and expending a lot of money. I'm bringing data to their staff and saying, if you want to help rural healthcare, this is a great way to do it. And look at the increase in access and look at the number of people who are using telehealth. Please continue to extend telehealth in Medicare or make it permanent. So I don't experience a lot of, policy that is outside of the worldview of the member of Congress that is somehow being influenced by lobbyists. I generally find that members of Congress and lobbyists who drift together tend to drift together because they already agree. And so I was a staffer on the Hill, and I really got lobbied by people that already were aligned with my boss. They would come in and say, okay, so how are we going to get this passed? Or how are we going to stop these other people from passing bills that we don't want them to pass? And it was more like a strategy working together than it was, hey, I gave your boss $1,000 and now you have to talk to me. It was much more like, our views were aligned, and I used lobbyists as outside advocates for what I wanted to get done.
Mm-hmm. And I know it was my last question. What are something that you look forward to in this next 4 years when it comes to healthcare policy?
They want to make some pretty big changes, and I think some pretty big changes need to be made. So I'm excited about bold moves. It's time for bold moves. I also am excited about the fact that they are focused on the root causes of chronic disease. The healthcare system tends to bear the brunt of all the complaints, but in fact, the food we're eating and lack of walkable communities and those kinds of policies are contributing to chronic disease. We need to talk about the upstream reasons that we're sick and not necessarily only about how long does it take you to get an appointment with your primary care provider, or how much prior authorization do you have to go through? Let's talk about food additives and agricultural subsidies that make corn syrup cheap. I'm looking forward to talking about other things besides, hospital lengths of stay. Let's talk about food additives.
Going back to the basic and the foundation of what make people have a healthier life.
We should really take advantage of this time for bold ideas. Republicans are, if last Trump administration serves as any experience, they are very open to big ideas and to really shaking up the system. So I feel like it's time for that.
Thank you for your time.
Thanks for having me.
Thank you for sharing your insight on the policy making in the DC area for healthcare.
Yes, take care. Thanks again for having me.
Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.